Greetings to everyone from Oswestry. My name is Birender Balain, and I've been asked to contribute to the case discussion for this fantastic conference, the Global Spine Endoscopy. So I present this case to you, who is a 31-year-old lady who presented to me in November last year with severe left leg pain and some back pain, but she was 18 weeks pregnant at that time. And the MRI scan, as you can see in the pictures here, shows you a large central disc herniation. It is predominantly posterolateral. It is affecting the left-sided S1 nerve root. But the patient did not have too much pain, and therefore a decision was taken to manage non-operatively. She went on to have a normal vaginal delivery just after 34 weeks. Then she came to me 6 weeks after her delivery, still breastfeeding at the time, but with a history of increasing left leg pain, increasing back pain. Now she's standing with a sciatic list to one side, but she had no symptoms of cauda-equina syndrome. And an MRI scan shows that the previously seen large disc has become even bigger. So it is going across the center to the opposite side, although she remains asymptomatic on the right side. You can see the extruded fragment coming down from the previous large central extrusion, and it extends almost to the middle of the S2 body. So the questions in managing a patient like this are about surgical technique. Either open or microscopic discectomy is a well-established way to look to treat this condition surgically. Some surgeons would just go from one side. Some surgeons would perhaps do a bilateral decompression but do a discectomy from one side. Is it possible to do this case endoscopically? This is a large disc, and quite often when people start to do endoscopy, they think, is it possible to remove all of a large central disc through the endoscopic approach? Is it possible to go across the midline to the other side, or is a bilateral approach necessary? And is the cauda-equina at risk while endoscopy is being performed? All logical questions. Here I show you the fluoroscopy pictures intraoperatively to show you the extent of play that is possible in younger patients, especially with the interlaminar endoscopy. So the extreme picture on the left side, you can see the standard fluoroscopy at the beginning of the case. You can see in the second picture from the left the superior extent of the dissection. You can see the inferior extent of the dissection, and you can see how far across the midline the Richard Wolf sleeve can pass to give you good clearance across the center to the opposite side. These are some intraoperative photographs. In the top left is the beginning photograph. You can see that the gap between the dura and the nerve root is bulging with veins and adipose tissue. As the clearance is done of the remaining part of the ligamentum flavum, the medial part of the ascending facet, and then going superiorly, which is shown in the fluoroscopy shot, and then the lateral decompression so that the lateral edge of the nerve root is identified, following which you do the nerve root maneuver, which allows you to see the disc. These are various photographs which show the disc fragments coming from underneath the nerve, and you have to work more to try and get all of that. The picture on the left, the central prominent bone that you see is the inferior end plate of the L5S1 disc. You can see this shot is across the, going across the midline, going behind the body of S1, and the bleeding can be very well controlled. And at the end, the nerve root is nicely decompressed. The gap in the axilla of the nerve root is no longer prominent because all the disc has been taken out. So the patient did very well, woke up with no leg pain, had mild numbness in the left S1 territory for 2 days and settled down after that. MRC grade 5 power, mobilized well, passed water well. These are the fragments of the disc that came out. and she's delighted with the result. As far as the risk of cauda equina is concerned, or cauda equina syndrome is concerned, as long as you keep the fluid pressure to 30 millimeters of mercury, you should be safe. Because you take the disc out in pieces or in fragments before you go across the midline, you're not pushing the dura out to put it to damage. Thank you very much, and I'll be delighted for any questions.